Hello, and welcome to today's webinar, Forsake Me Not, How HCH Providers Can Deliver Better Care to Pregnant Women Experiencing Homelessness. This webinar is presented by the National Healthcare for the Homeless Council as part of our spring virtual training series, Her Health, Her Housing, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. I'm Barbara DiPietro. I'm the Senior Policy Director at the Council, and I'll be the moderator for today's discussion. This is a 60-minute presentation, and we're going to endeavor to have the last 10 minutes reserved for Q&A. There's a chat box at the bottom of your presentation slides for your questions and any technical issues that you might be having. Type your questions or your issues into that chat box at any time during the presentation, and we'll either address your technical questions right then, and we will save your questions for the Q&A section. If we, by chance, can't get to all of your questions today, we will log them. We will then provide written responses to your questions after the webinar is done. If you're still having technical issues, you can call Cecilia at 615-226-2292, extension 241, and Cecilia will help you. Also, for those who get continuing education credits, this session is accredited for one CME credit hour through the Vanderbilt University Medical Center. So there's a downloadable claim instructions that are located in the CME Information pods to the right of the slides. If you plan on claiming that credit, download that document, follow the instructions there, and that claim code that you need will only be available during this session, and it'll appear in the last 20 minutes of the presentation. So in order to get your credit, your CMEs must be claimed within 3 days of this presentation. So that's how the whole CME thing works. So with that in mind, let's just plunge into a really exciting discussion. As I had mentioned, this is sponsored by HRSA, and this is a standard disclaimer about that and our funding. But even more important, let's talk about our presenters today. We've just got a really rock-solid team from San Francisco today to talk with us about a really important topic that I think we often overlook in our clinical discussions. So without further ado, Deb Bourne is a physician working as a medical director in the Transitions Division of the San Francisco Health Network in the San Francisco Department of Health. Dana Lazarovitz, I'm sorry, Dana, I told you I wouldn't mess it up, but Lazarovitz is a nurse with the Nurse Family Partnership in the San Francisco Department of Public Health. And then Brianne Taylor is a community health researcher in the California Preterm Birth Initiative with the University of California at San Francisco. And the three of them have got extensive knowledge on this issue, and I'm just really excited to have them join us today to talk about the model of care that they've got going on out there that I think offers lessons for all of us. Want to jump into the expectations that you have for today. So we have 3 learning objectives. By the end of this, you will be able to, hopefully, understand why treating pregnant patients is important, learn more about provider bias and system barriers that can undermine the effectiveness of care. Even when that's not our intention, sometimes we mess up. And so how can we be honest about that discussion of the bias that we bring as providers? And then third, how do we identify elements of a successful care model that we can use to better treat pregnant women experiencing homelessness? So that's really where we want to go today in today's discussion. And then I think Hannah has got a poll up here just so we can get a better sense of who you are in the audience and getting a sense of how or whether you are providing care to pregnant women. And so we'll just take a couple of minutes to get a sense of who's out there in the world learning about pregnant women and this model of care. And we'll just wait again for a little bit more of that to come in. And so far we've got a pretty good mix of people who are providing direct care themselves, as well as perhaps they don't, but other people in their health center do. I'm glad to see that it's such a small section. No, not at this time, but we're still running about 25% more or less for not providing care and possibly not in the near future. So maybe this discussion is really give you some ideas for how you might be able to move forward on that, or even taking incremental steps to establish the kind of partnerships we'll talk about today. We'll just give this a couple seconds more. Again, a good mix of folks. And so, yeah, so okay, so I think that gives us an idea that we've really got a diverse clinical presentation here. And with that, what I'm going to do is just one last note here. Throughout this discussion, we are going to be talking about women who are pregnant. And we want to acknowledge, just in terminology and being accurate and inclusive, that we know that there are a number of people who are non-binary identifying or other folks who can become pregnant. But for the most part, we are talking about cis women. And so, again, but while we will be using the term women, we mean that in an inclusive way to address any patients that you are serving who may be pregnant. So with that, I will turn it over to Dr. Deb Bourne to talk with us more about why HCHs should be serving this population. So take it away, Deb.
Thank you, Barbara, and thanks everyone for taking the time in your day to sign in. And a special shout out to the people that were the 21% that don't take care of women that are pregnant, that you actually are interested in the topic. It's always strange to do a webinar because I can't see your faces, so just take a smile to yourself because you took the time to sign into what I think is one of the most important topics that I've worked with and advocated for in the last 30 years. So why do healthcare for the homeless programs and providers need to take care of pregnant women? I can tell you a little bit about myself in that I used to do obstetrics and deliver babies. I'm a family doctor and take care of families when I lived in New York. And I moved here to San Francisco 13 years ago, and I knew I was going to stop delivering babies, but I didn't know I was going to stop seeing pregnant women. And if one of my patients became pregnant, we didn't see them in our health center because we don't, quote, take care of pregnant women. Even for colds, I couldn't see someone. And over the years, I've realized and come to know that this is not a unique situation for many healthcare for the homeless programs. And I still think it's strange because we have a whatever it takes attitude. All of us will do whatever it takes for our clients and whatever it takes for our programs. We'll develop office and street-based buprenorphine programs. We, SSI, go on the street, go to shelters. But why, when it comes to pregnancy, we stop that? If I have a patient who has brain cancer, I don't stop taking care of them because I'm not the brain surgeon. So this talk's not going to be about why we don't. I'm going to talk to you about why we should with some evidence and data. First of all, we're seeing women of reproductive age. From the national data, 23% of all of our HCH consumers are women of reproductive age. That's almost equivalent to the 26% in health centers. And having worked in a health center, I can tell you the feeling around reproductive health and wellness is much different. It's foremost in the work of health centers, but not in many of our HCH programs. So in street medicine, we were noticing that we actually were seeing women of reproductive age mostly outside of the clinics in the urgent care, but not necessarily in the clinic. And we weren't doing a lot of reproductive health with family planning, what we thought was only reproductive health. And so we did a survey on the street and encampments of women of reproductive age, and 91% of the women that we talked to had been pregnant before, and 70% of them have actually given birth. And you can see down the bottom, there's some demographics that number changes depending on age group. So we asked the question, where is that baby that you gave birth to? And out of the 34 women that we talked to, the majority of women had their children removed and many had relinquished. The green group, other, is the relinquished group. So we knew we were seeing women of reproductive age, that many of them had given birth, and most of those who had given birth don't have custody or didn't have custody of their kids. So we wanted to do family planning. Where do we do it? Oh, we'll just do it on the street. I talked to a lot of my friends who worked in Africa. They just set up little booths and put in Nexplanon, gave birth control. So we started an initiative that's called Street-Based Encampment Health, where we're doing low-barrier STI screening, HIV, Hep C testing, and buprenorphine. We take care of men as well, but we're targeting women of reproductive age that weren't coming into health centers. And we offered family planning, but we had a very low uptake on the family planning and thought, wow, we're just not marketing this well. So what do we need to do to ask women to get them to take birth control? Well, we were lucky enough my slide is not working. We are lucky enough to actually have a grant from the Society of Family Planning, the Innovation Grant, and we asked women, if you could start any birth control today, what would you do? And 40% of those women said nothing. Some women said, 30% said birth control of a pill, 20% said condoms, and 10% said IUD, and no one wanted that magical next one on that I was so excited to put in their arms. So then we asked another question. Would you like to be pregnant in the next year? And 40% of the women said that they wanted to in encampments and 86% in methadone clinics. And then we asked another question, how would you feel if you found out you were pregnant today? And 50% of the women said happy. So we realized we were asking the wrong questions. And I was sitting in a room with other clinicians and researchers, and we all think ourselves pretty groovy. And we realized that we are so biased. And I am humbled at looking at my own bias. I've been doing this work for many years. And why is it to me that even though I'm seeing pregnant women on the street, why is it an emergency? And even though I pride myself in my ability to be consumer first, why is it that I'm injecting my bias so that you need birth control? Women are women regardless of where they live. Women are women regardless of their social determinants of health. And 50% of women wanting to be pregnant is pretty average. So I have to say that one of the things I want you to take away from here is the importance of looking at our own bias. I'm still mesmerized at how much work I have to do. So another thing that I've learned in the last 6 years is really most of my work is with high users, very high use of the ED, decreasing cost, but looking at the hidden cost and where we're actually not taking care of folks. There was a cohort with our HIV program called HIVE, and they looked at the women and their viral suppression over the course of their pregnancy and postpartum. And 90% of women can take a pill every day and be virally suppressed when they give birth. But as they followed their women and they left their specialty pregnancy program, only 67% of those women engaged in routine primary care to stay virally suppressed, and 44% at 12 months. In my own research, I do clinical research of mobile medical care with folks that are living on the street with chronic, with HIV, mental health, and substance use. And of that cohort, the women who had lost custody of their children, who had their children removed or relinquished, had the lowest rates of viral suppression, the lowest rates of stabilization, and the lowest rates of becoming housed, which made me realize that the high users aren't the only population we need to focus on. This is one of the most important areas of prevention and intervention. The stigma factor is huge. So why should HCH providers support pregnant women during pregnancy? Well, we're caring for women of reproductive age, 1 in 4. Most of those women are pregnant, have been pregnant, or will be pregnant and want to be pregnant. Many women don't stay in care after they give birth, after the specialty service. There aren't equivalent services for them. Women who have had their children removed or relinquished have experienced increased trauma and increased stigma, more than we can even measure or count, and it is impacting their ability to care for themselves and engage in care, and our ability to figure out what kind of programs they need. Pregnancy is a unique opportunity to make a change in the trauma and stigma cycle, mostly because we have services for pregnant women, and we do need to be pregnancy neutral, but it is a unique time, and we need to take care of all women in every stage of their life cycle, not making pregnancy a hot potato, but taking care of them before, during, and after. I'm going to hand things over to Bree.
Thank you so much, Deb, for sharing why providers should support women during pregnancy. I will now be discussing what providers need to know from pregnant women who are homeless or experience housing insecurity. So again, my name is Bree, like the cheese, and I am a mother who was housing insecure while pregnant. Because of my experience in failing to navigate the prenatal care system and search for stable housing, I became overwhelmed and extremely stressed out. I had some family support to rely on, but it occurred to me that other women who are homeless might not have a family community to rely on. I began to ask why. Why does one of the wealthiest cities in the nation have such a large homeless population and some of the worst health outcomes for the majority of its pregnant population? After asking why, I became involved with qualitative research, specifically community-based participatory research. I am now a trained community researcher, and as such, I'm able to contribute to projects that directly affect my population. My work focuses on pregnancy, low-income women of color, homelessness, and housing insecurity. And I hope that I'm able to lead by example, that all projects directly affecting my demographic, community, population be co-led by community with lived experience. The best person to help inform a remedy is the person experiencing the problem. I have been involved in 3 studies that utilize qualitative methods and employ community voice. My research has allowed me to hear from other pregnant women who are experiencing homelessness or who are housing insecure. I've spoken with program managers who house these women, and I have also interviewed providers that care for pregnant women who are homeless or housing insecure. And the results from my research indicate that women are stressed out, that provider bias creates fragmented care, and that we have forgotten what it means to have compassion for one another. What I've learned about the impact on health and well-being: pregnant women who are homeless or experience housing insecurity are under extreme amounts of stress, so of course that puts them at risk for poor health and poor birth outcomes. Our mothers are our first home. Stable housing is critical to improving the health of pregnant women and lowering rates of prematurity. Compared to babies born to stably housed mothers, babies born to homeless mothers have an increased risk of dying within the first year of life. Programs that are created to help house these women, such as rapid rehousing, ideally work great, but in reality further exacerbate fragmented care and creates a feeling of a silo. The women are removed from the environments that they grew up in and are moved to communities where they don't know how to access resources, transportation services, and if they're on Medi-Cal, it often takes months before they're able to access the care in their new county. So they either go without or they choose to continue care in their original county, which then creates a transportation burden that further stresses them out. What I've learned about the access to services and housing. So pregnant women who are homeless or experience housing insecurity fall into a gap in health services and housing. Pregnant women without children living with them are not considered a family and are ineligible to access family-specific long-term housing or transitional or shelter housing. So they're no longer a single person and not yet a family. In San Francisco, through the Rapid Rehousing Program, they're not prioritized for shelter or housing until they're in their 3rd trimester or 5th month with a high-risk pregnancy. And at that point, it's too late. Women share that they are persistent to getting services and housing. And during one of our mama sharing sessions, a woman said, "I was instructed by one of my family members to go apply for welfare, even though my husband worked. So I basically had to lie to get housing faster." And that was like a huge lesson learned. But it was either lie to get on welfare to get public housing or we'd be homeless. We also heard from women that they experience their male partners are not supported by the system to be involved. When it comes to the experience of care, pregnant women who are homeless or experience housing insecurity are less likely to seek prenatal care because of provider bias and a lack of wraparound services. They often feel that providers and care teams operate with an equality perspective rather than an equity perspective. With equality, everyone has access to these resources. But as providers, we need to go back and look at it at an equity perspective. What do I need to do to help you access these services? And finally, I've learned that women are strong and are resilient beyond measure. They lean on religion and social support, and they want quality care. They are also the experts in what they need. Again, the best person to inform a remedy is the one experiencing the problem. Thank you so much, and I'm going to pass it back to Deb.
It'd be nice if I unmuted myself. Thank you, Bree. I enjoyed listening to that. And if we could have, as providers, even a 28th of the courage that the people that we serve and the women like Bree that we're serving, we really could make a deep change. So I'm inspired, and I want to talk to you about what you can do today after you get off the webinar. So this is what you can do to, regardless if you're going to take care of pregnant women or not, this is what you can do today. So in San Francisco, people were seeing women that were pregnant and that were experiencing homelessness. And it became like a hot potato. If you see the woman that's experiencing homelessness, you need to get them off to the next thing. And it also was causing a lot of trauma. I work with a homeless outreach team and street medicine, and people were so overwhelmed in shelters. If they saw a pregnant woman, they didn't know what to do. So we got together and realized that we could start to help and support each other. So we worked with the methadone clinic, the homeless outreach team, street medicine, who I work for, labor and delivery at the General Hospital and at UCSF, OB and GYN clinics, homeless prenatal, which is a wonderful social service agency in San Francisco, public health nursing, housing partners. We work with Compass and our HIV program, Hive. And we started first with call me whenever you need to. So we would call each other as experts. I'd be on the street. I would call Nika, who's our OB expert. They would call me from the hospital. We would consult each other. And then we started what I called the Committee of the Willing, which we were willing to actually do something about the care of the women that we're seeing in front of us as opposed to hot potatoing them out. And we started to work together informally, serving clients to make a change. And every woman we worked with, we let them know, we're working and you're teaching us how to help you better. In the last 2 years, it's been super exciting. So we realized that the fault was with ourselves, and we realized that we had to get it together. As Bree was saying, we needed to deal with our own bias and how we were actually making sure that we had equitable service and service access. We don't even have good data in San Francisco of the numbers, and we certainly don't know where in the system women are actually touching. So the first thing we did is realize that there's 4 levels of care that you could embrace. And I think in San Francisco, we're probably at 40%. I look forward to coming back next year and doing a webinar where we're at 60%. But many of the programs that we're working with do not have specific funding to work with women who are experiencing homelessness. We're working together to make each of our jobs and our work better. But things have been changing. At the very least, what you can do after you get off this webinar is in the orange. You're a healthcare for the homeless provider, you're an OB provider, connect with each other, be an advocate for each other, for the women by being consultants to each other. I often get phone calls, what do I do, where do I go, how's this service? Just be there for each other. That alone, if you could do that in your areas, you're going to make some huge headway. The next and magical thing that we're going to talk a little more about is working with public health nursing and their program, specifically Family Nurse Partnership. They are HCH providers who are out in the community, who go where women live. And many of the public health nursing folks that we worked with didn't know where to find the women that were experiencing homelessness, didn't know about going into the shelters. And we partnered with them to actually help them access and go help work with the women that we're serving. They really do work like community health workers. I do have to say a not-so-secret desire of mine. I hope someday that we have doulas that are going to be with women as community health workers from the time that they find out they're pregnant, not just when they're given birth. And work like public health nurses and with them to actually expand the services that we're doing. So that's a goal. Shout out to there someday. Doulas for all. We also have some programs in San Francisco where we do mobile case management. We have a great homeless outreach team. They do work with pregnant women, not specifically. And we have some new funding through our HIV program, Hive, that's called Team Lily, and they serve women that are currently using substances during their pregnancy. And in the blue, street medicine, we don't turn any pregnant woman away. We take care of them. They are our patient. But the most important thing is that we all have the same health outcome. And I look forward to our 40% Committee of the Willing to actually be concrete programs and services. With that in mind, I'm going to turn it over to Dana, who's going to talk about her amazing Family Nurse Partnership program. Dana?
Okay, I unmuted myself. Thank you, Deb. Nurse Family Partnership. So let me move the slides here. Am I moving?
Sorry, Dana. There's a technical issue with our pictures are overseeing our words, so everyone's getting, and I apologize for that.
Okay. Okay. Well, missing one of the slides where it says, how can HCH providers and specialized public health nurses collaborate to support women who experience homelessness? So the easy answer to that is we can find each other and work together. We are doing it in San Francisco, and this is how. In San Francisco, public health nurses are mobile. We are where the HCH providers are. Here in San Francisco, we partner with the homeless outreach team and street medicine to outreach to pregnant women. We leverage and learn from the relationship and expertise of HCH providers, what they know about homeless women, and together we try to support their engagement in pregnancy care. We fill in the large gaping gaps to care and try to bridge access to prenatal care and other resources. In San Francisco, the Nurse-Family Partnership Program and our sister program, Field Public Health Nursing, serve as a low-barrier intervention for pregnant women experiencing homelessness to begin to engage in their prenatal health. We support women to find accessible OB care, work with HCH providers to find shelter, housing options, offer substance abuse options, provide evidence-based pregnancy, childbirth, and parenting education, advocate and educate around CPS issues to keep families together and thriving. So this quote is popped up here, and I am like continuously fueled by this quote by Dr. David Olds, who's the founder of NFT, and if you know me at all, I'm sure you've heard me cite this before, but I'll read it because I just think it is like so important and speaks to the work. So there is a magic window during pregnancy. It's a time when the desire to be a good mother and raise a healthy, happy child creates motivation to overcome incredible obstacles, including poverty, instability, or abuse with the help of a well-trained nurse. The Nurse-Family Partnership is a community health program that works by pairing at-risk first-time moms with specially trained public health nurses who visit regularly in the client's home or anywhere in the community from pregnancy through the child's second birthday. Sorry, the lighting is like crazy in here. It's an intensive, long-term, early intervention that is preventative to have an impact on these moms and babies. The inspiration for this program is the premise that with the right support, pregnant women experiencing homelessness and other challenges are capable of profound change. And saying that this time can be magical is not to romanticize the struggle, but to emphasize the uniqueness of this pregnancy window and to highlight the opportunity and the importance to offer services. And like Deb was saying, when we remain neutral, so not invested in particular behavior changes, that women can feel safe to move through the stages of change. If I meet a pregnant woman living on the streets, she doesn't feel ready to come inside, she's not interested in substance abuse treatment, that's cool. That is totally fine. My work with her is not predicated on any kind of requirement that she be ready now or ever to do those things. Her pregnancy is still worthy of thoughtful attention. And it is my firm belief that every pregnancy is. In NFT, we affectionately refer to this practice as following a woman's heart's desire. And Deb has reminded me that in other realms, we also call this harm reduction. Okay, so I'm going to move the slide here. Okay, so how does this work? The model is executed by experts, specially trained nurses, but not just experts in pregnancy and child development, but in this particular model of care that so carefully addresses the needs of vulnerable women. It is proven, okay, so nearly 40 years of extensive and compelling evidence. And it is intensive, right? Pregnancy through age 2. So 2.5 to at least 2.5 years, sometimes more, okay? And the reason for its intensiveness, right, is because getting through the pregnancy is just one part of this, right? So much opportunity for growth and learning, so much possibility happens after delivery. And when there is a trusted relationship, that work can really happen. And trusted relationships take time. And then it's timely, right? So it focuses on the first 1,000 days, okay? And we know that the first 1,000 days are, I'm going to move the slide over here. are critical for development. Oops, too fast. Sorry. Did I go back? Okay. Sorry. So the first 1,000 days are critical for the development of mom's maternal role and confidence, and specifically for a child's brain development and attachment. The first 1,000 days can be a reliable predictor of a child's future outcomes. For this reason, it really behooves us as providers to load up services on the front end, really thinking about prevention and long-term benefits. Okay. So, lucky for all of us, NFP is everywhere. It's in 42 states plus the Virgin Islands, and it's still growing. At HCH providers, if you feel like it today, you can seek out your local NFP agency, or you can also call this 800 number and find out if there is one nearby. Okay? Do I have time to talk about a case? Yeah? Okay. Okay. So I, as I was preparing this, I was thinking super fondly of a client I'm currently working with. She had been homeless for many years before learning she was pregnant. She had an established relationship with a homeless outreach worker who brought her into prenatal care, where I also got to meet her and enroll her in NFP. She moved into shelter at a navigation center with her partner and remained there until she delivered. I visited her often during her pregnancy, at least once a week, and just provided her pregnancy support, checking in, providing education, just what she needed. She, at this time, she continued to struggle with substance use, and when she had the baby, she and the baby tested positive for drugs. CPS detained the baby, and the baby was placed with family. My client at that point was motivated to enter into residential drug treatment, and when she was discharged from the hospital, literally the first thing she and I did was go to that place for intake. Within several months, her baby was returned to her in the program. She successfully completed 1 year of residential treatment, and soon after, her CPS case was closed. Currently, she's living in her own place in permanent housing with her baby. In the fall, her child will turn 2. She will graduate from the NFP program and have 2 years sober. My support, the support of her homeless outreach worker, and of course, her amazing resilience, was unwavering, right? So despite her kind of not following through with the things that she wanted to achieve in pregnancy, we still showed up because her pregnancy still meant something, and we still believed in her. And I feel like when we do this, that there is so much impact, and that we really make a difference. What hasn't surprised me in providing the NFP model to pregnant women experiencing homelessness is that they are having positive birth outcomes, term, healthy weight babies, breastfeeding, etc. Because these outcomes are proven in NFP. I have come to expect them. But what has been surprising is that many of these chronically homeless women are moving off the streets and eventually into permanent housing, where they are staying successfully. And it feels like a real lasting impact, a small dent in the homelessness crisis. In conclusion, I believe strongly that public health nurses and other providers taking care of pregnant women can work with HCH providers to make the system accessible in a way that is equitable. Because, and this is Deb's quote, people don't fail the system fails people, especially when it's assumed that a one-size-fits-all approach is going to work for all pregnant women. Thank you. Oh, and back to Deb.
Thank you, Dana. It's so beautiful hearing the stories of these humans that I got to have a little piece of their life. I'm going to go over some take-home points. One big thing I want to tie into some of the data that we know from street medicine is there's a very high likelihood that if you're seeing a woman of reproductive age, she has actually had her custody relinquished or removed from her. and the impact on the stigma that we can't see. This is not a disheveled individual with long hair pushing a carriage. These are human beings that actually are so resilient, looking very well, and we often, we can't measure the amount of stigma and shame that happens and the impact on women's ability to make change. And part of it is because we're not creating systems and spaces like Dana's program, which does, for women to work through those issues and gain strength. These women are doing so well. They're on this. They're survived because of their resiliency, and I feel like that's an important topic and a whole other conversation. I do want to say, for the most important thing as a policy statement and issue nationally, we have to make this the forefront.
It sounds like we lost Deb, so we'll experience a technical interlude while Deb calls back in. In the meantime, I would like just to take an opportunity to ask if you have any questions, type them into the box, because we are going to be coming down to getting to your questions and want to make sure that we're maximizing the folks here on the call. Dana, I know you talked earlier about some of the clients that you're seeing and talked about some of the women that you were caring for in the program. And I'm curious if you've got another patient that that you've been caring for that illustrates some of the concepts that we're talking about that have benefited from this partnership that you might be able to share with us now.
Sure. So I will say that I have been interested in a long time in thinking about how we take care of homeless pregnant women, and I was like constantly frustrated by feeling like I just didn't have what I needed to address their greatest needs. And so it has been so amazing working with Deb and other HDH providers to figure out a way to really make pregnancy services accessible for these women. But I think about like another woman, and I smile when I think about her, because I didn't get to meet her until she was 28 weeks pregnant. She had been seen in a methadone clinic her entire pregnancy, but for whatever reason wasn't connected to prenatal care, which is like another thing that we have kind of worked hard to like solidify partnerships with. But when I met her at 28 weeks, she was interested in getting off the streets, and I supported her to do that. And then we just went through this like intensive, like she was interested in like everything having to do with pregnancy. She wanted to learn everything she could to have a healthy pregnancy. And by the time she was ready for delivery, she was like, I want to have a home birth with a tub, and I want to deliver in the water, and she wanted delayed cord clamping, and like was so like interested in learning and doing the best that she could for this baby. And I feel like she always had that in her. She just needed like an opportunity for somebody to recognize her pregnancy and to give her some care, And that mom too is in treatment still, and her baby is 6 months old. She's also in permanent housing, and I just feel super proud of what we've been able to achieve with the partnership with HGH, and really kind of just giving women the care that they deserve.
That's fantastic. I'm curious, and so one of the things that one of the participants had sent in is curious about how you formed your strong relationships with the providers in your area. Can you talk to us a little bit more about how you reached out and how you created partnerships, maybe even with people who were skeptical about taking on this population?
So I'll admit that Deb actually sought me out and was curious about what my program was and what I was doing with pregnant women, and we kind of just like began to learn from each other. In my practice in general, as a public health nurse, but also as a case manager for my clients, to have really good relationships with the OB providers, with the Deb, are you back? Shelter staff,
yeah.
to make sure that that I can advocate for clients and make sure that we're all on the same page. And I'm going to give it back to Deb because I think she has some really good insight on this.
Oh, and Deb, you
the stories are better. I'm going to just wrap up if that's okay, Barbara.
Oh, sure, no, absolutely. And we can come back to this too.
No, I'm thinking of some of the other folks. I literally had one woman and her partner, with a discordant couple. The partner was HIV positive, and we tried everything to get her to engage. She was still really active in her addiction at the time. And finally, I just yelled, "I'm trying to get on Ellen DeGeneres, and I know you have what it takes to make it. So please just come out there, and someday we're going to be on Ellen." And we're going to be on Ellen together. The baby's 2 years old, and he's doing so well. But these women are just unbelievable, and it was the magic word to her when I was actually, I brought a lot of chocolate too for a couple of weeks, but so chocolate helps. But just figuring out actually what to make us as providers seem more human to the women that we're serving. And the fear of CPS, the fear of the stigma is so huge, and here I am, just this, person coming in. It does help to work with the homeless outreach team and other consumers who actually gave me street cred, and they actually were really helpful as well. I'm going to get back to the things that you're going to do as soon as you get off this webinar. Yes, Bree. So the values and missions of HCH have to be part of our program, and we need to look at all of our agencies and look at where we can make sure we're serving pregnant women. You don't have to take care of the pregnancy. You can just serve the women. And you can partner. After you get off this phone, you can call your labor and delivery office. You can call that number. It's like I told Dana she's being the best dating service in the country to get people together to do this work. And we can work with the shelters and let them know, call me if you have a pregnant woman. You can do all of that as soon as you get off the phone. I just want to remind everyone that 21% that said they're not going to take care of pregnant women, you don't have to be the pregnancy expert. You don't have to do and take care of the pregnancy. You can partner with the pregnancy experts and with the public health experts. All you need to do is be you and your HCH expert self and make sure that we're addressing this issue full force. Bree?
Thank you, Deb. I would really like to echo a point that you made earlier. When the providers are no longer in the provider frame, when they come to us as patients and as humans, it's much easier to continue care. And as I was interviewing some of the providers for one of the studies, she said that when she cares for women who are homeless or who are housing insecure, she takes on a trauma-informed perspective. So when she relates to the woman on a personal level, that patient is more likely to continue care. So really just being personal can really be what the women cling to and want, and what makes them want to continue that care. And I also would like to echo your doula point. The women that we spoke to often didn't know what doulas were, and the ones that did really advocated for those at the beginning of the pregnancy, and again, not just during the pregnancy or during the delivery. So doulas are so important. They really help uplift the culture of pregnancy and care that is outside of what we consider correct medical care. There's culture care that is just as important. So really, it's all-encompassing.
So I appreciate that point, and I'm curious too. We had a question come in about the impact of programs providing care to pregnant women. So have you seen the health outcome measures of their babies increase? So, for example, birth weight, survival after the first birthday threshold, developmental issues, anything like that that you've got or tracking data on or have seen?
Am I on? Yeah? Okay. So Nurse Family Partnership is an evidence-based program, and because of that, we collect so much data. And while all of our clients are not homeless, we do kind of capture data about the ones that are. And we do see that these women are are having healthier pregnancies. Their babies are being born firm and at a healthy birth weight. They are initiating breastfeeding, and the data continues and the outcomes continue until 2 years when we stop collecting them. But we know based on the NFP randomized control trials that are still being followed today that these children are having like long-term positive impact from being cared for in this way during their pregnancy. But I still think like that there is need for more data collecting, you know, maybe even from the HCH side, which would have like a different perspective.
Deb, and I know you've been having some technical issues with your phone. We were talking about the health outcomes of babies that you've seen through this partnership, and so Dana was talking about some of the things that she's seen. Don't know if you wanted to add in anything about the documented measures.
Well, it's interesting. The low birth weight initiative in San Francisco that Brianna and her colleague Jessica can talk more about, when the money first came from Benioff to do the low birth weight initiative, I went to meet with their director and said, can I talk to you about homelessness? And she said, no, this is going to be about color and poverty. We're not going to be talking about homelessness, so thank you so much for coming and talking to me. That the issue wasn't going to be about housing. And I said, no, the issue really is about housing because poverty is a crime in this country and it's hard to get housing in San Francisco. And it's been so interesting to watch the whole process come full circle. I didn't even tell Brianna and Jessica about this. But to see that actually housing from this community collective, and you can talk more about it, Brianna, how the low birth weight initiative really came up on their own, all the stakeholders, that housing is one of the #1 issues to actually improve the care for women. Brianna?
Yes, thank you. And being housing insecure is very, affects the preterm birth and low birth weight. I think there was a thing right here that caught my eye. Oh, no, sorry. But yes, to bring it back to the topic, women who have the highest low birth weight and preterm birth are women who are homeless or housing insecure, living in public housing, things like that.
We've had a question too come in related to this, saying that our challenge is tracking outcomes as they don't have funding for research. Where did your group develop your concept of doulas for all? And where have you started? How did you get that going?
So me, in my mind, I've been saying this, Brianna's group also has said that, but community health workers have significant impact. My clinical research is on community health workers and the impact on health outcomes and engagement in care. In my clinical work with HIV, having a navigator, we have folks that are experiencing homelessness. The average viral suppression is 30%. With community health workers, it's 79%. So we know that there's concrete impact of having the community health worker, which public health nurses are doing. And so doulas are evidence-based intervention during birth. And the concept would be, and I'm not the expert, so I've always secretly wanted to be a doula, not so secret, that we actually just stand and hold space for human beings to do what they do well. And that's what a doula does. And that's what a good community health worker does. In terms of data, we don't have enough data. And in San Francisco, it's actually one of the things that's had the hugest impact. In the times that we want to get together and write grants, we really are not tracking, especially on HCH, who we're seeing that's pregnant. I think mostly because of the stigma and the hot potato that we actually say, we don't take care of them, and then we send them off. We've been working more with the police department and with Healthy Streets programs and even with our DPW to actually put some emphasis. And I do think that we need to look at this population with the same kind of public health aggressiveness as we do with PrEP and HIV prevention with MSM or trans community. We have to say that these women are out there and they're invisible, and we need to help get them in a healthy way into care. So I hope next year we come back with lots of data, because this is going to inspire all of you to actually collect the numbers.
Got it. Bree, I want to come back to something that you had talked about earlier in your slides that came from the research that you've done. And you were talking, one thing you had said was when hearing from women who are pregnant and homeless that male partners were not supported by the system to be involved. And I was thinking of not just their male partners, but just thinking about family and support systems broadly for women who are pregnant. And I'm just curious if you could talk a little bit more about ways that you have found to maximize the social supports that people have around them, whether that's with intimate partners or with family or others.
Yes, thank you. One of a story that really touched me when it comes to partners and family and resources, there was a woman delivering, and at the hospital, she was not allowed to have her community in the room with her. There were about 15 family members that showed up for her, and that was her support to deliver. She wasn't allowed to have that support, and that detrimentally affected her labor. She ended up needing to go into a C-section because she was just really stressed out the whole time. I think that when it comes to hospitals involving the family, they need to be open to just, I understand that there are regulations and rules around the number of people that can be in the rooms and things, but I feel like there are exceptions made for other groups that are not made for the homeless and low-income women. So really letting go of our biases around that, and also the community-based the community-based organizations like Homeless Prenatal Program and Black Infant Health. Those are really there to support the women who don't have a lot of medical knowledge and things like that. I really want to echo Deb's point about doulas. Doulas bring a lot of information, and they really stand for the pregnant women when they may not know what to do or who to ask for help. I think that there are a number of resources now that doctors are provided, that a list that really goes into detail about the different community organizations that are out there now. So I think that we're doing a good job of expanding our knowledge of the programs that are out there, but I don't think we're really there yet.
Barbara, can I say one thing about family as an HCH provider and talking what Brianna's saying? So as we know, many of the people that we work with have disconnected from their family of origin and what is family. And unfortunately, we had a death of one of our most beloved moms after she gave birth to two now healthy twins. And when she was very clear of who she wanted to be her next of kin, and her mother was not her biological mother, it was her street mother. And it was really, took a lot of advocacy to make sure that she was the one to make decisions. So who people's family is up to them and not up to us. And a lot of what we do in HCH is actually help make that so. So we really are the experts in that advocacy, and it really brings a lot to the picture. But healthcare for the homeless providers are advocates, and helping bring voice is what we really do best.
Right. Deb, one thing I want to come back to, and this isn't exclusive to Deb, but I know you've got such a strong piece on provider bias. And you were talking earlier about how we, in the provider community, presume that women do not want to be pregnant, and so we tend to come at it from a, let me give you as much birth control as I can, and then we wonder why that may not be effective both for the service that we're offering as well as the broader relationship that we're trying to establish. What's your sense of how best to talk about provider bias with other providers as a way of getting people to see the lens that they're bringing? How do you talk about bias in a way that people hear, I guess?
Well, I don't know if I have the key yet. There is on the resources a wonderful film made in Canada just about that issue. It was made by a group of women who've experienced homelessness when they're pregnant. And it looks at what the providers are thinking and what they're thinking, and it's a wonderful piece, 16 minutes. You can watch it after or later tonight. So I try to be transparent and use my own example. I am humbled, as I said, where I am constantly learning from the humans that I'm serving. I do know that we have to make ourselves available, and it's trauma. What I'm seeing a lot is the trauma of my colleagues is so great because they don't know what to do. We did have a woman that was pregnant, a very high user, actually the 4th highest user in the city of emergency services, and she kept on going to labor and delivery. And after her birth, she was able to stay with the baby, help feed the baby, and she boarded with the baby. And I just worked with all the pediatricians and the OBs to show them what she did. There was a woman that I saw yesterday who had actually syphilis, was homeless on the street, and had 3 visits to the labor and delivery floor. She gave birth and chose not to stay with the baby, and she had a lot of trauma. We work with her very extensively on the street, and she came to me, and she's sick with another illness, but she came and trusted us because she knows we love her, regardless of what choices that she had to make at the time. So I think number 1 is look at yourself. Number 2 is show examples, and show examples where they're actually doing well. How much better that feels, and then show them examples of success, because we cannot say what success is for a human being. We can only say that in every opportunity there's a seed. And so because we had a relationship and a trusting relationship with this woman who had only had about 5 minutes with her baby's life after the baby was delivered, she still was there with us, and I feel like those are things that we can all do. There's also a connection to Matt Bennett, who's my favorite trauma-informed teacher, Connecting Paradigms, and he is a great resource because looking at how the system must be trauma-informed, Barbara, as well as our programs and ourselves as individuals, really is the special sauce.
Dana, Bree, anything to add to that?
The bias piece, because it's huge, Dana. I mean, we cry about it after. How do we help our colleagues?
So, I just want to kind of like add to the bias piece, not to like make the situation seem more kind of dire, but it's not just a bias about like thinking that pregnant women or homeless women don't want to be pregnant. It's like an added, more like sinister bias of feeling like women who are experiencing homelessness should not be pregnant, right? Like the audacity of these women to want to have children. And I think that is like the really dangerous bias that we need to be kind of like confronting and admitting to and consulting with our providers and people that we trust about like how do we get through this, because that is where the system fails these women, right? And so so those are the things that I work on myself on a regular basis, but also kind of encourage and invite people to think about.
Barbara, we have a continuation of our Society for Family Planning Innovations grant. We have a consumer advisory board of providers and consumers with lived experience, and we're looking at this piece. We're trying to create trainings and toolkits, so I'll bring all that back to you as soon as we learn more. I can't say enough about the opportunity to do research and be funded for these things.
Got it. Real quick, I know we just got a couple minutes left, so if we can take 1 minute with one last question. What message did you use to connect with HCH providers? Do you have a couple of suggestions there?
I mean, it was not at
Dana?
all like formal or like technologically advanced. We just like called each other on our cell phones, and I think we all, homeless outreach team and the public health nurses have access to the same electronic health record, and so we tried to coordinate around that. But it was really just like, I need you, you need me, call me, and we'll figure it out. But I think that there's so much like work that can be done and needs to be done around formalizing this, so that more women can get served and not fall through the cracks.
Great. I know we're right up on time. I want to respect folks. Please note that the CME credit code is up on the screen right now. So if you are claiming CME, grab that information there along with the instructions in the box below. And frankly, I just want to thank you guys so much. Bree, Dana, Deb, you were fantastic. I think this is a really meaty issue that we hardly even scratched the surface of today. There's so much more to talk about. So thank you again for pitching your expertise on our spring webinar training here. Just for everyone who's still with us, the link to this archived webinar will be available on our website at the conclusion of our training series this month. The slides are available here in the pod if you'd like those. And again, make sure that you're filing your CME within 3 days if that's where you are. And then as soon as this ends, an evaluation survey will pop up. So please let us know how this met your expectations for today's topic. And again, with a final just thank you to my speakers. Thank everybody else for coming today. Really appreciate your interest in this topic. There will be more that we will have to present on this in the future. So thanks again, and at this, the webinar is closed.